I want to thank NTRK Connect for inviting me here to share with you the series of case studies of patients who received TRK inhibitor therapy. My name is David S. Hong. I'm at the University of Texas MD Anderson Cancer Center. I'm professor and deputy chair in the Department of Investigational Cancer Therapeutics. These are my disclosures. So in the 1960s and 70s, neurotrophin receptors were discovered, and they were discovered to bind to a number of different ligands, specifically BDNF, NGF, NTO4, and NT3. These receptors appear to have a role in controlling things like pain signaling, thermoregulation, movement, and proprioception. And it wasn't until the 1980s that scientists discovered that these receptors and the gene specifically could fuse with other partners, leading to constitutive activation of the NTRK gene and receptor, leading to cancer and tumorigenesis. So in the mid-2000s, I had the privilege of being involved in the development of larotrectinib. And you can see there are two drugs now currently approved for NTRK fusion patients. These approvals were really kind of landmark approvals in cancer therapy, in that these were one of the first therapies targeting NTRK fusions, but specifically in a tumor-agnostic manner. You can see here the response rates and the differences between larotrectinib and entrectinib. Overall response rates in the high 50s and 80s and 70s overall. Median progression survivals significant in the sense that these were really metastatic, many of them chemo-refractory, standard care refractory patients, and with little toxicities as shown here. I want to share with you the most up-to-date data set that we presented last year at ASCO. Dr. Drillin, my colleague at MSKCC, who also helped lead the larotrectinib approval, presented this data. At that time, the FDA approval, in the previous slide, we had only about 55 patients enrolled. Currently now, we have close to 244 patients. You can see here the demographic profile of these patients, the most common tumor types being soft tissue sarcomas, other rare tumors such as infantile fibrosarcoma, but other common tumors such as thyroid, lung, and colon are represented. These patients spanned a gamut of different ECOG status, as you can see here from 0 to 3. We did allow in the clinical trial, in the phase 2 clinical trial, even patients with ECOG 3, and many of them had prior systemic therapies greater than 3. You can see here also that in this accumulation of the data, we also allowed for pediatric patients in addition to adult patients. The patients were all identified to have some type of gene fusion. The two most common TRK promoters were TRK1 and TRK3. And this slide always amazes me. Despite the fact that we have now added 4 times the number of patients, the overall response rate remains incredibly high. Response rates were close to 80% among 18% of these patients with baseline CNS metastasis. Again, were 83%. We've had close to 21% complete response rates. And again, high response rates, very similar to the original data set. And again, when we look at overall duration of response, progression-free survival, and overall survival, it remains impressive. The duration of response is close to 33 months, median PFS close to over 2 years, and overall survival has yet to be reached. I want to share with you several of the cases that either my colleagues or myself have treated in the past. And first case is a case of a lung cancer patient with both intracranial and extracranial response to larotrectinib. This patient was a 76-year-old woman with metastatic disease both to the lungs and the brain. She had no prior systemic therapy because she had refused platinum doublet therapy, which, as many of you know, platinum therapy can be significantly toxic in elderly patients. She went on to be treated with larotrectinib. She was confirmed to have a PR or minus 34%. But you can see here both in the images listed here, both on the CT of the chest and also MRIs of the brain, she had a near complete intracranial complete response. She remains on therapy over 6.5 months at the time of presentation. I want to also highlight another patient of mine, in which, although rare, I think is an important case because it may help us define a subset of patients with MSI high colorectal patients that may benefit from larotrectinib. This is a patient of mine. She's an 85-year-old female presented with obstructive symptoms. She was found to have MSI high or DMMR mutated patients. She had also on the NGS found to have a NTRK1 fusion. She went on to receive larotrectinib for 2 months, but had rapid progression of her disease. And it's not clear at this time since the number of these patients are low, but it may suggest that these patients with NTRK fusion and MSI high may not be as responsive to pembrolizumab as other MSI high patients. Subsequently, she enrolled in our phase 2 larotrectinib study, the Navigate trial at 100 BID. She did have grade 3 LFTs, but we went on and allowed her to remain on study as per protocol and reduced her almost in half to 50 milligrams BID. On her first restaging, however, even with a lower dose, she went on to have a confirmed PR of 42%. Now, she started in 2018. Almost 4 years later, she remains on trial. And you can see here the images of this large mass in the liver, which is significantly reduced, and she continues to have some reduction in her disease. Okay, so the last case I want to share with you is this case of this LMNA NTRK1 fusion soft tissue sarcoma. And the reason I share this with you is that she was literally the first patient on our phase 1 trial. She was a 42-year-old female, a mother of 3 with undifferentiated sarcoma, who had progressed through pretty much all lines of standard care therapy with sarcoma, high-dose epirubicin, high-dose ifosfamide, sorafenib, doxorubicin. She went on to the phase 1 trial at 100 milligrams BID, and then had rapid resolution, both of her dyspnea and hypoxemia. And as you can see here, had a remarkable response. We had to call this a PR because she still had a little ditzel down here in her diaphragm. We published this in Cancer Discovery. My colleague, Dr. Doble, did in 2015. And she remained on study almost since 2014 to now, if you think about it, almost 9 years. She just recently progressed and came off. But again, a representation of how dramatic and how life-saving this therapy can be. And so it really, I hope that you would come out of this lecture series to point out it is incumbent that we identify these patients and find these patients really to help these patients, because this drug can be truly life-saving. All right, I want to thank you. This is my staff at our phase 1 unit at Houston. If you ever have a chance, come to Houston, please come and visit us. I want to thank again the NTRK Connect folks for allowing me to present these cases. And of course, we want to thank our patients and our caregivers for taking part in these trials. Thank you very much.